Okay, and as usual, as we do with all these ISN GLOMCOM seminars, these are an educational partnership between ISN and GLOMCOM. I welcome you on behalf of our group, and I will be your moderator today. I don't need more introduction. Welcome to our 2023 mini-line on seminar series. This is our seminar number 2. And I have the pleasure to introduce our speaker today. Thank you for accepting, and I will stop sharing my screen so Wesam, you can.
Yeah, I think we're on now. Okay, welcome everyone. I'm going to present a case today. I think it was an interesting case. There is a differential diagnosis, and maybe we can go through it together. So our case was a female who's 24 years old who presented with loin pain, progressive rise in serum creatinine. When she presented, it was 1.6, then it became 1.2. Yes.
Sorry, so we are not seeing your slides. So if you can.
You're not seeing my slide? Okay.
No.
Oh, I'm sorry.
Just go to the next. Probably now it's moving. We are seeing only the first. Okay, here we are. Yes.
Well, you can see my slides now.
Yeah, we do.
Okay, excellent. So again, this is a female who's 24 years old and presented with loin pain and progressive rise in serum creatinine from 1.6, then became 1.8, then 2. Her past history was not really significant. She had a history of tonsillectomy with query rheumatic fever in childhood. She's not a known hypertensive or diabetic, and her investigations were negative as well. She had no significant family history except for a father who was a known stone former, and the parents had negative consanguinity. Her investigations showed serum creatinine was 2, urine showed urine red blood cells from 30 to 40. Her albumin creatinine ratio was only 650 milligram. ANA, double-stranded DNA, and ANCAs were negative. C3 and C4 normal, and virology was negative. Sonography showed bilateral grade 2 nephropathy. Her right kidney was 9.4 by 4.6, and left kidney was 11.1 by 4.9. Renal duplex studies showed normal vasculature. Echo for her history of query rheumatic fever showed only mild mitral valve prolapse, a mild trivial tricuspid regurg, and her ejection fraction was fine, 70%. So she was recommended for a renal biopsy. I'll show you this is her first biopsy, and her first biopsy was disappointingly enough a minimal biopsy, which showed an acute tubular interstitial nephritis. And at that time, we said that maybe it could be granulomatous TIN, or maybe an infection like pyelonephritis. However, following this biopsy, her serum creatinine continued to rise to 3.8, and proteinuria started to increase and ranged between 1 and 2 grams. So the biopsy was repeated in 3 months. As you can see, this was her biopsy when she was repeated. And can you see the arrow? So we had a good core this time, and you can see in the tubular interstitium that the core, that it was completely infiltrated by numerous granulomas. As you can see here, this is an H&E, and the granulomas were actually confluent together. They had also epithelioid cells and large joint cells with what we can call Langerhans joint cells. These were her glomeruli. The glomeruli were slightly ischemic, but there was nothing other than that specific in them. Maybe the glomerular basement membranes were a bit prominent, but then this is due to the ischemia. There was also a prominent interstitial infiltrate in the background, but this interstitial infiltrate was mainly lymphoplasmacytic. There were no significant eosinophils or neutrophils in them. Again, this is another picture with stain showing you the granulomas. And so these are epithelioid granulomas. They did not look caseating. There were no necrosis in them. And they seemed a bit like glomerulocentric. However, it seemed here, as you can see in this picture, that the granuloma is actually destroying the Bowman's capsule. So it is originating from the tubular interstitium, and it's destroying the Bowman's capsule, as well as here, and that we had significant interstitial infiltrate. Her immunohistochemistry was completely negative, and her EM unfortunately showed medulla. So the diagnosis was granulomatous TIN, possibly drug-induced. However, ANCA-vasculitis and other causes like tuberculosis and sarcoidosis are to be excluded first.